Surgineering is the fact that he early detected the essential importance of collaboration among radiologists, surgeons, computer scientists, and so on. And he was one of the first people all over the world, as I know, who consequently integrated it into training and education. Professor Siewerdsen, we are looking forward to your presentation.
Thank you very much, and I hope you can hear me okay and see my screen. It's a real honor to provide a keynote address at the CARS 2020, and I want to begin by thanking the organizers, Professor Lemke, Professor Feuchner, of course, for the invitation. And I'm sorry I can't be there in person. As Dr. Feuchner introduced, my name is Jeff Siewerdsen, and I am the John C. Malone Professor and Vice Chair of Biomedical Engineering at Johns Hopkins University. And it's a real pleasure to talk to you today about surgineering, which, as I'll describe, has as much to do with how we educate biomedical engineers as it does how we collaborate with surgeons. I won't talk much about my research today. In fact, I'll barely mention it at all. But I hope you agree that what I describe in surgineering as a curriculum has at least as much potential for positive impact and benefit to the role of engineers in medicine. I'd like to start by thanking the numerous clinicians, surgeons and radiologists and more who contribute to the surgineering program. And I'll come back to several of them during this presentation. I also want to acknowledge funding support for the curriculum from the John C. Malone Professorship and also the Department of Biomedical Engineering at Hopkins. And a few disclosures for myself in terms of sponsored research agreements, licensing agreements, and advisory board service to industry partners. As we've heard, in September of 2018, Professor Feuchner and co-authors published this paper in IJCARS called Surgineering, in which they outlined a new type of collaboration. Of course, it starts with identification of a genuine clinical problem and a technical solution. But rather than seeing that forward to a potential technical cul-de-sac, there's an iterative process, as shown earlier, where the surgical operative technique itself is iterated upon in combination with the technical development and therefore having a greater likelihood of success. In June of the same year, on the other side of the Atlantic, I gave this talk at Johns Hopkins University entitled Engineering, Physics, and the Hospital as Laboratory. And within that talk, I also invoked the term surgineers. So we were thinking alike. And by that, I meant an engineer and data scientist who's on the clinical team, whose focus is the same as that of everyone else in the room, specifically the safe and effective treatment of the patient. Of course, the surgeoneer is observant of challenges and is an advocate of innovation. Their ultimate goal is to bury the complexity of systems surrounding the patient to allow more innovation and bring positive change. So a year later, we published our experience with the surgineering concept within the curriculum at Hopkins BME, also in IJCARS. And concepts within that paper, again, of course, there's the clear need to identify genuine clinical problems, to provide biomedical engineering students with genuine clinical exposure, understand real problems and challenges, and the concept of insight-informed innovation, and not a technology push, but an innovation born of genuine clinical need. But I think these are things actually that we tend to do fairly well in biomedical engineering, and we aspire to always do better. But in surgineering, we're thinking at higher levels, really, of elevating our thinking to the level of systems that are surrounding the patient and the operating room or the hospital or even the healthcare system, incorporating data-intensive approaches to make these systems into a more continuously learning machine, and potentially generating a new workforce. And I'll say more about what I mean by a surgeneering workforce, but ultimately I think this is inevitable, that there is such a player within the medical workforce. Now, I have to admit that I was a bit self-guided in this approach to realizing the ideas that we had to see this curriculum forward. But this picture is really emblematic of the life of a professor anyway, really. So for the next couple of minutes, I want to at least share with you some of my experiences that shaped my outlook on the role of biomedical engineering, physics, and computer science in medicine, and how this shaped my thinking and what we've rolled out within the surgeneering curriculum. And it starts way back in my graduate experience. So here's a photograph of me sleeping under my desk as a graduate student. And there's nothing special about that. Lots of graduate students do that, and they're thinking about things that graduate students think about. For me, it was the relationship between the noise in an image and the blur in an image, and that's the relationship if you're interested. But the really important thing about this photograph is where it takes place. And specifically, it was in the basement of the medical center, and specifically the radiation oncology clinic at the University of Michigan. So right outside the door of the lab is the cancer clinic. And our research was conducted every day right alongside the delivery of care to cancer patients. And the technologies that we were developed were informed by that daily interaction and inspiration. Now, fast forward a few years to William Beaumont Hospital, where I worked with Dr. David Jaffray on the development of cone beam CT systems. And here you see a lab which shows cone beam CT systems that incorporated flat panel detectors early on surgical C-arms. And then this device here is actually the blank gantry drum of a linear accelerator where we built flat panel detectors on for cone beam CT guidance in radiotherapy. But here again, the important thing about that photograph is where it's taking place. The lab was a bunker within the radiotherapy clinic. It was actually another radiotherapy vault without the linear accelerator installed yet. And so that work, again, was informed on a daily basis by interactions with clinicians and inspired daily by the presence and interaction with cancer patients. And when we moved that technology out of the lab, it really just came out the door and next door and implemented on a linear accelerator for first clinical studies. And to this day, that shapes my outlook, the context and environment surrounded by clinical insight. So this is a photograph of Johns Hopkins University here, Johns Hopkins Hospital here in Baltimore. On the left is one of the research towers. On the right is one of the clinical towers, specifically where most of the operating rooms are. And I'm really happy, and I feel quite privileged to say that our base of operations for research and education is here in the heart of the hospital in some of the operating rooms of the Hopkins Hospital that were functioning right up through the end of the 20th century. And moreover, where we teach surgeneering is right here in the heart of Hopkins Hospital, where we really couldn't be any closer to clinical operations. In the lab, I said I wouldn't talk too much about my research, but we work on things like 3D C-arms for cone beam CT, integration with tracking and navigation systems, the development of navigation systems that have streamlined registration or maintain registration of the tracking system during surgery, even when the anatomy is deforming. We look at video augmentation and video systems, either through augmented reality or direct projection of information on the patient, registration of the endoscopic scene in real time with CT or MRI to provide information beyond the visible scene of the endoscope, in this case in skull-based neurosurgery. Integration of imaging systems with robots, either relatively complex robots or simpler robots that may be well suited to a particular surgical task. And of course, 3D imaging for either diagnostic or image-guided procedures is very close to my heart. But all of that research, goes on in a context that looks like this. Here's a photograph of a meeting that takes place 2 or 3 times at my lab. And The color labels here show some of the types of people that represent the interdisciplinary work that goes behind that kind of work. It includes engineers, clinicians, industry, and students. And we'll come back to those 4 key players within this field in a moment. So that gives you some idea of the environment that sort of shaped my thinking and my approach to research. And I'm really lucky to have that complemented over the years by many individuals who said things that helped to shape my thinking. So 11 years ago, when I came from the University of Toronto to Johns Hopkins University, I learned of a course called Surgery for Engineers that was led by Dr. Mike Marone, who's a general surgeon, and Dr. Russ Taylor, who's a computer scientist, whom I think many of us in this conference know very well. And the name of that course really stuck with me, and I could see that there was a real gem in that course. It was a 2-week summer course taught at the engineering campus, but it stayed with me for a decade. And the students with whom I spoke really found this class to be remarkable in helping them understand more of the foundations of their research. But a second person I want to mention again is David Jaffray. We saw him earlier. He's my mentor at Beaumont Hospital, later at University of Toronto, and David is now at University of Texas, MD Anderson. And 2 years ago, he gave a talk at Johns Hopkins in which he discussed the complexity in medicine and the influence of nonlinear events in technology development. And I'll say more about that now. David gave that seminar in this room, which is called Hurd Hall. It's a very storied lecture hall at Johns Hopkins Hospital. And David described a few things, and one of which was the relationship between the complexity of systems and the number of things that we pile into the system. And of course, there's some form of proportional relationship between the two. As we pile on technologies, a system becomes more apparently complex, or I might say complicated. And it approaches some limit beyond which a human really cannot perform productively. Then something happens. Some kind of nonlinear event, some kind of innovation. And often this is a piece of technology. It could be a mechanical engineering innovation. It could be computer algorithm, but there's something that resets the curve and then allows the innovation to proceed. And implicitly, the performance of what we're trying to accomplish improve along this curve. Again, it approaches some saturation of human bandwidth limits. This is when we feel like we're trying to balance too many things and we can't move forward. It's a big inhibitor to innovation until once again, something happens, resets the curve and allows for more innovation. And intrinsically, as I'll say in a moment, I feel like this is fundamentally the role of the surgineer, is to reset the curve. Biomedical engineers, computer scientists, or physicists were all very good at driving us up the curve. But this is the thing which I hope to accomplish by way of this vision for the education of biomedical engineers. David talked about many more things, including the fusion of IT and technology to transform the hospital into a continuously learning machine. He talked about the relationship of quality and safety in research, which is something I find really profound. He talked about capturing all of the data, not only from surgical processes, but from life in general, and capturing and curating all that data in the interest of learning. And he talked about the agile cooperation among those same 4 players that I just showed, the clinicians and the researchers, the industry partners, and the educational programs. David was actually deploying surgineering at the University of Toronto. He called it surgility, and he employed, I think, about 4 engineers that he deployed out into the hospital under his program for information technology and research. And I thought that was really great, but I couldn't employ 4 people full time to put out in there, and I wondered, well, how can I see this kind of a picture forward? And that's when Mike Miller said something to me which I thought was very important. Mike Miller is the chair of biomedical engineering at Hopkins, and he said many wise things over the years, but something he said to me resonated, and he said that our curriculum is shaped by our research. And for me, that was a really liberating moment. It gave me freedom to teach beyond the textbook and to say, well, gee, the things that I'm really best at and the things that I really care about could be a way that I bring biomedical engineers to the edge of what we know and let them push it even farther. And so how can I do that at a program like Hopkins BME? It's already a really great program. It's the top-rated undergraduate program in biomedical engineering in the US. It's the largest program in the Hopkins School of Engineering, and it helped to define the modern curriculum for biomedical engineering at the undergraduate level. And it's doing it again with a BME 2.0 and project-based learning. Its master's programs are really strong in entrepreneurship and innovation inspired by genuine clinical need. And the PhD program in faculty, again, it's the #1 graduate program in biomedical engineering in the US with translationally oriented faculty. We are very happy to be co-located in Hopkins Hospital, where we enjoy strong clinical and industry collaborations. So how can I add to this great program, which I'm humbled to work within? Well, here's what I did. Surgineering as a curriculum is 2 semesters. The fall semester is called Surgery for Engineers, and I've accommodated up to 20 to 25 students within that course for 2 years. And the spring semester is Surgineering, and that's in the spring, and we shrink it down to about 8 or 10 students who really want to go deep. Now, I know the text on this slide is too small to read, so I'll zoom in. The Surgery for Engineers class really emphasizes fundamental principles and practice of interventional medicine, really gets at the fundamentals. There's brief lectures, but it's mostly about hands-on demonstrations and lab and visits to clinical areas. And each of these segments is led by an expert in a particular discipline. Surgineering, on the other hand, really takes it to a higher level. It really combines aspects of systems engineering and data science. And the work that we do in that class is predicated on experience gained from deep clinical immersion from each student, where we match each with a clinical faculty person who oversees their immersion in a patient care pathway and actually involves them on clinical teams and gives them a job within the care of patients. We focus on challenges of technology integration, data flow, workflow, patient safety, QA, not device innovation per se, but really thinking at higher and higher levels of care around the patient, from the care team to the operating room, to the operating department, the hospital, the healthcare system. Well, on the left of this slide, it shows some of the topics that we cover in the fall course. It's really about fundamentals, and there's a premise here that to be a better innovator, you really want to understand both the basics of the procedures within which you're innovating and the context that surrounds that. There are many stakeholders in every operating room, and it's not just the surgeon. And so those kinds of fundamentals, somewhere within the first week or 2 of class, the classroom looks like this. And if you're wondering, why is there a watermelon at every station? It's because you are at the intersection of good ideas and crazy ideas, or at least I hope so. The watermelon's a good model for wound vac. This is something that every med student learns. It's so students learn the principles of negative pressure wound preparation and the wound vac. And so each of these watermelons has been wounded. You see this student has obtained negative pressure on a fairly complex wound, and students like this exercise a lot because they can eat their homework. But the theme continues, why bananas? Well, of course, bananas are a common model for understanding the basics of suturing. Different types of needles, sutures, different kinds of knots that you can execute. And I really want to thank Sandra DeBrito. She was a general surgery resident at Hopkins who provided a lot of the vision and inspiration and groundwork for this. But this exercise is the premise, right? If you're going to invent a robot that ties knots, right, you want to understand how to tie knots and what are the challenges with tying knots and what are the different knots and what are the different types of suture and so forth. And really understand that context more fully. We extend that quickly up through concepts of electrocautery and bovie, harmonic scalpels and debriders, more complex systems. And we learn all the general surgical instrumentation. And here's Dr. Marone, 10 years later, since the original Surgery for Engineers course was offered long ago, here he's teaching principles of laparoscopic instrumentation. We interact with other folks. We learn the general principles of general anesthesia, how to obtain airway access, and what are the challenges in obtaining airway access, or in laryngoscopy, and things accelerate from there. Within the Minimally Invasive Surgical Training Center, or MISTIC, at Johns Hopkins, which is directed by Dr. Gina Adrales, and she co-directs this course in surgery for engineers, particularly through the general surgery segments. And here you see students hands-on now with laparoscopic simulators, with real tissue. They learn the principles of port placement, which is such an important aspect of surgical setup and workflow. And then we get head down into the Da Vinci robots and the Da Vinci trainers. We cover a spectrum of surgeries. For example, in orthopedic surgery, Greg Osgood walks students through the principles of fracture fixation and joint replacement. And here's where the vendor representatives become especially important. The kinds of instrumentation you're seeing here are very much cost prohibitive of anything that an educational program such as this could support. But moreover, the vendor reps are really expert and knowledgeable and terrific teachers you'll find in working with students on these kinds of standard instrumentation. The students get to get their hands dirty. Here's a Surgineer putting a total knee replacement into a sawbones model, and a little bit of high tech. Here's a virtual reality trainer for total knee replacement. But as you can see, the emphasis is really on fundamentals. And we learn open and minimally invasive spine surgery techniques, such as pedicle screw placement with or without navigation. And here again, the vendor reps are walking the students through a number of navigated tools. Students get to try their hand on pedicle screw placement, both in models and in cadaver. And here's Dr. Nick Theodore taking them through the systems for real in the operating room, including navigation and surgical robotics for spine surgery. There's a fair amount of imaging in the course, but the students learn the principles and algorithms behind various medical imaging modalities and other coursework. And here we really focus on the fundamentals, the practicalities of, let's say, fluoroscopy, and what constitutes the inlet outlet views. What are the bottlenecks around fluoroscopy positioning? Ultrasound with a skilled ultrasonographer, and why is there so much user dependence in ultrasonography? Here, cone beam CT in the operating room. Here's a student delivering pedicle screws within a cadaver under navigation, and interventional MRI. In otolaryngology, John Carey, Deepa Galaya, Pete Creighton are ENT surgeons who come, and we take the students through ear surgery, including microscope-assisted staphotomy and cochlear implant. And we go beyond surgery to interventional radiology. Here's Cliff Weiss, who leads the students through hands-on labs in RF ablation and cryoablation. And here's a student doing an ultrasound-guided biopsy. So this is a simple jello phantom. And you see a successful core biopsy of this needle deployed through the pimento of this olive under ultrasound guidance. But it gives the students a feel for what are the real and practical challenges. And we really expand it to all of interventional medicine, in fact. And so the course rounds out with a couple of areas, one being radiation oncology. And this is Todd McNutt teaching basic radiobiology. But even more importantly, and really quite a lot of fun, we team up and we gather around real treatment planning systems. So these are pinnacle treatment planning systems for radiation therapy. And students learn the concepts of conformal and intensity modulated radiotherapy. They learn about objective functions and constraints, and they team up and they each form treatment plans for radiotherapy of the prostate. And there's an award for who gives the highest quality treatment plan in terms of the dose volume histograms to the normal and target tissues. Of course, we tour the radiotherapy clinic, including image-guided brachytherapy clinic, where students learn the complexities of patient setup and so forth, and gynecologic brachytherapy, which is the specialty of Dr. Viswanathan here, who is actually the chair of radiation oncology at Hopkins. Now, you might have heard professors say to never leave your back or turn your back on the classroom. And here's what can happen if you do. In surgery for engineers, as I returned to the physical medicine and rehabilitation lab, one of the students had gotten into the walking assist rig, and he was heading around the track, and the students were having a great time on the last day of class. Associated with the classes, of course, in surgery for engineers, there are labs. There are 3 main labs where we cover principles that are pretty fundamental to engineering, and these are more the comfort zones of the engineers, really, including image registration, multimodality images, and phantom or clinical data. They learn the fundamentals of slicer and principles of an objective function or similarity metric, a motion model, be it rigid or deformable, and optimization. There's a lab on surgical tracking. Of course, there's a whole course on this led by Russ Taylor in computer integrated surgery, but we exercise it here as well in terms of point-based registration, various tracking technologies, and experiments that are intended to measure factors that affect registration error, and really thinking about how that propagates forward into realistic clinical environments. And finally, there's a lab on robotic guidance where with a simple robot, in this case a UR3, students learn about tracking a robot and guiding it with some path planning. And there's a moment of truth at the end of the class where the students have to target a stray marker. So I will place this marker on the optical bench somewhere, and the students need to hit it with the robot. And here is a successful example of that. So there's the pointer, there's the stray, and so that's a passing grade in the robot guidance lab. In the spring semester, the clinical rotations are really important, and I said they're deep clinical immersions. So each student does 3 rotations of 2 weeks each, paired with a clinical mentor. And these are more than just shadowing or observation. Some surgeons attach the student to a patient, and they follow that patient through their care pathway. And they're observing and understanding all the intersections of different systems within the hospital around that patient within their course of care. And others give the students a job to do in the clinic. Maybe it's pulling data for a case in clinic, or pulling images up that are going to be used in the operating room. And so they really get a job. That's pretty formative, and I think it deeply affects the students to really be given something important to do. To the extent that the mentor judges appropriate within the practice of medicine, of course. And the themes that they're thinking about, again, are really at levels of workflow and system interactions, data, especially ephemeral data that's captured to answer a particular question and then is gone. And so the surgeoneers ask the question, well, how can we capture and curate that data and learn in a way that will improve the quality of the next case? And they study safety, adverse events, and root cause analysis. And there's no better example of that than shown here. This is a rotation that's available to the students in the Capacity Command Center at Johns Hopkins. And you see it's really a flight control center for the hospital, where it tracks the flow and management of patients in transfers between hospitals into the emergency room, the operating rooms, and the intensive care units. And it's this incredible eye-opening view of the data flow surrounding every patient, every day, in every department. There's some content to the course, but as you probably figured out now, it's largely experiential. But some of the content that we deliver involves principles of systems engineering, including workflow analysis, human factors engineering, root cause, and we do a lot of case studies. For example, this is Donna Bedian's model of structure and process and outcomes, and how we can model an environment to understand the factors that affect the workflow or safety of that in qualitative but also rigorous terms. And the other aspect of content within the course is data science, mostly around image analysis and natural language processing. So we cover some basics of neural networks, including a genealogy of neural networks that helps students identify a particular architecture that may be most useful to a task that they're trying to accomplish. And so we study, for example, the UNet for image analysis and BERT for natural language processing. And the culmination of the course really is in the spring projects from Surgineering. And some of the projects over the last 2 years are shown here. And several of them are really noteworthy. One involved a team that developed a 3D or 4D simulator of MR-guided neurosurgery to study workflow analysis. And they iterated on this through hundreds or maybe thousands of simulations to find how the workflow configuration or just the orientation of systems within the operating room might be better configured to shave upwards of 12 minutes off of an MR-guided neurosurgery procedure. State prediction based on either anesthesia data or video tracking within the operating room. Natural language processing by Alexa is a popular choice. digital pathology and image analysis to ease workflow bottlenecks in digital path. And of course, this year, 2 of the Surgineering teams responded to the COVID-19 emergency. One team developed a box to decontaminate N95 masks using ultraviolet light, including a nice simulator, a 3D simulator environment that they used to design the box. And in the end, it was a box that could decontaminate multiple masks uniformly in less than a minute. And then another team helped to develop a rig for testing the integrity of the filters in N95 masks after processing with ultraviolet light. And more importantly, they developed a QA system, a statistical model that said, well, look, if you have 10,000 masks within the healthcare system, how many of them and how frequently do you need to test masks to have 95% confidence that the masks within the system have high integrity? And that's a great example of QA integration with research. The outcomes of the course were very good in terms of so these are 5-point scale surveys from Surgineers after their final exams in the second year of the course. And so the quality and challenge associated with the course were deemed good to excellent. And here as a reference are course averages from across courses in the department. I did well, but most importantly, the teaching assistant. It's really important to have a great TA to help with this. And in fact, I would say a full-time lab tech, which is what I did last year. It was really helpful to this. On the right are word cloud representations of the free response, the best aspects of the course. Of course, the best aspects of the course was hands-on experience with surgeons. The worst aspects of the course were the early hours and so the morning and getting to campus on time. But even that we had class at 8 a.m. every day. But it wasn't enough to diminish the enthusiasm of the students for this course. Following, well, back in the fall of 2018, when Feuchner's article appeared in IJCARS, I wrote this opinion piece in Hopkins Medicine where I talked about the Surgineer as a means by which we could bury complexity in the operating room. And this year in Hopkins Engineering and Hopkins Medicine, they highlighted the latest from both the Surgery for Engineers course and the Surgineering course. So just to revisit that article and how, in my view, Surgineering as a curriculum can help to raise the level of thinking of biomedical engineers to a systems level, incorporate it at the interface to data-intensive approaches and create continuously learning machines rather than just adding machines to the system. And is there a new workforce? Well, I think so. In fact, I think it's inevitable. If we look at the curves of complexity versus the number of things, we know that it's not sustainable. And as things accelerate and our healthcare systems become increasingly complex and saturated, we really need engineers who understand the fundamentals, but are great innovators in order to help us hit those nonlinear events and reset the curve that will promote new innovation. I want to conclude again by thanking the clinical collaborators who are really integral to this program. Clearly, you can't run a course like this without the expertise and time given by these fantastic clinicians, but also the vendor reps, as I mentioned, who give their time to give a demo and lend instrumentation for a course. But finally, of course, I want to thank the students of both the Surgery for Engineers and here the Surgineering class of 2019 and 2020. And of course, the spring semester this year was disrupted. And so the last many weeks of the semester had to be conducted remotely. But that didn't stop these Surgineers from teaming up and doing great projects, even though they conducted them remotely. And all of which resulted in BMES abstracts, which hopefully we'll be able to present this year at the BMES. And with that, I want to thank you very much for your attention. I hope that you see my vision for what Surgineering can be in terms of a training ground for the next generation of biomedical engineers. And if you're a student, maybe there's something in there that helps to shape your thinking, just as my thinking was shaped growing up in research clinics. And I hope one day that you actually have a job title of Surgineer. And if you ever have a business card where you're hired on as a Surgineer, please send it to me. And maybe I really hope that I could have a job posting in the future where we would hire a Surgineer. And if you're a professor, I hope that that you see also that Surgineering is as much about the productive collaboration with the surgeons as it is about how we create the next generation of engineers. Thanks very much.
Thank you very much for this really outstanding presentation.